Can I invite Dr. Jagrati Khudania? Please come and give your presentation.
Good afternoon. I'm going to present a case on snake venom ophthalmic uveitis. To begin with, snake venom ophthalmia is caused by venoms of spitting elipid and other snakes. Among snake species, spitting cobras, a member of the elipid family snakes, can spit venom from juvenile gland while irritated or threatened. After a toxin spray attack, the eyes are most often affected, causing inflammatory responses in the anterior segment of the eye. In venom spray ophthalmia, many symptoms such as periocular soft tissue swelling, hyperemia, conjunctivitis, corneal epithelial erosion to corneal opacity, uveitis are common complications after venom spray. Ocular complications in the posterior segment are often observed after snake bite. So here, a 12-year-old female presented with burning sensation, watering, redness, diminution of vision and pain in the left eye since one day after experiencing snake spit. Her visual acuity in the left eye was 6/24. On further examination, the conjunctiva was mildly congested, cornea was mildly hazy, and fluorescent stain positive lesions were present in the pupillary area along with dusting capes on the endothelium of the inferior quadrant. The patient had aqueous cells and flare 1+, and the iris was grayish-brown in color with mild changes due to edema. Her pupillary reaction was sluggish, although. On fundus examination, the media was slightly hazy, and the optic disc was apparently normal. The ocular examination of the right eye were not that significant. The findings were not that significant, rather. So a diagnosis of snake venom ophthalmic uveitis of left eye was made, after which copious irrigation of the left eye with normal saline was done after installation of proparacaine 0.5% eye drop, and the patient was put on a combination of moxifloxacin and dexamethasone starting 6 times in the left eye for 2 weeks and gradually tapering over an interval of 2 weeks. Along with that, the patient was prescribed atropine 1%, eye drop olopatadine and carboxymethylcellulose 0.5%, and the patient was advised to use dark goggles and review after 1 week. So during the follow-up, the congestion was reduced. Also, the fluorescent stain was negative, and the cells and flare were absent in the AC, and her visual acuity from 6/24 improved to 6/18 in the left eye. And in the follow-up during the second week, her visual acuity further improved in the left eye to 6/9. So concluding with that the spitting cobras, along with the elipid family, belong to the elipid family of the snakes. Snakes of these species have characteristic fangs with anteriorly placed openings and can spit venom up to a distance of 8 to 12 feet. It is the nature of the cobra to spit venom at predators or prey, and humans are accidentally affected. These snakes can also directly transfer venom via bite. Spitting cobra venom contains a mixture of neurotoxin, cardiotoxin, phospholipases, and cytotoxins. Cardiotoxins with the membrane-lytic properties are thought to be responsible for the corneal erosions and conjunctival chemosis. The ocular effects of the venom depend on the duration of the contact of the ocular surface with the venom. Delay in washout and increased exposure can cause scarring of the cornea and loss of vision. Ocular contact with snake venom results in pain, diminution of vision, blepharospasm, conjunctival inflammation, and chemosis. Initially, there may be small fluorescent staining corneal epithelial defects. The epithelial cells, they lyse to form a larger epithelial defect or erosion. Systemic effects of snake venom ophthalmia have not been reported. Copious irrigation of the eyes with water at the earliest is the single most important step in management of this condition. This removes venom from the eyes and hence prevents corneal damage due to various toxins in it. Topical steroids, antibiotics, antihistaminics, and anesthetic eye drops have been reported as treatments for snake venom spit ophthalmia. Heparin, owing to its chelating agent, has been shown to effectively reduce venom-induced ocular complications in experimental studies. However, it has not yet approved for clinical use. Since there is no evidence showing that the antivenom treatment elevates venom spit ophthalmia, topical or IV antivenom treatment is neither necessary nor recommended. These are my references. Thank you so much.
Thank you. Any comments?
Yeah, doctor, your references, do they talk of the same type of snake?
Ma'am, I'm not sure about the snake variety because the patient was a kid and neither the attendant or the patient were not sure about what kind the
No,
snake
not
was.
in your case. Your case, you did say that it was a spitting cobra. Your references, I'm asking.
References, ma'am, it is related to basically the cobras of the species.
So these were all cobra
Cobras,
studies.
yes,
It's a very interesting case, I must say, because I haven't seen this. Is a very interesting case.
We did not, like, this is the first case I've seen.
This was a kid?
Huh?
This was a kid?
12-year-old kid, female child.